Hey guys, we're live again. We're going to be talking with Dr. Kavusi, Parviz Kavusi. We've had a little delay because of the rain, so we're going to actually be doing that talk here while we're here in Santee. So Dr. Kavusi is at Austin Infertility, and we'll get him on in a few seconds here.
You want a chair?
No, it's fine. Wish we had signal like this. We're on a landline right now.
Yeah. You know, we have a ton of cover in this guy. He has service.
Hey guys, we're live. Dude, I don't know where. I'm sorry, Austin, not Italy. Buddy. Hey, can you turn off? Okay. I can't hear you, man. We can't hear you. Mic off? We can't hear you. You wanna hold on? We can't hear you. Log off and log on. Can't hear you. But we can see you.
Keep it. My gift to you.
When I have the phone like that, can you hear it?
Is that working there? Hello?
Hey, Parvi. Hey, I can hear you now.
Oh, can you hear me now through the...
Yeah, we can hear you now. How are you doing? Yeah, we can hear you now.
Oh, hold on, let me try it again.
No, I can hear you. I can hear you. Don't try it again. I can hear you. Oh, I can't hear you. Now I can't hear you. What did you do? We'll just do it on the phone. You just put your next to you. We'll do it using the phone. Hey.
Trying different settings here. How's that? Can you hear me?
No, we can't hear you. We could hear you about 2 seconds ago.
I can hear you now. Can you hear me?
No, we can't. What's going on?
Now I can't.
Can you hear me there?
Oh yeah, I can hear you now. I can hear you now.
Okay, I'm going to hang up on the phone.
Dr. Kavusi is not even say he's a colleague. I would say he's a very good friend of ours, and we worked very closely together. He is one of the few in the nation that actually does robotic microsurgery. He is a proud member of Ramsey's, which a group we talked about earlier today, and we're very excited to have him talk with our group. Dr. Kavusi, thank you so much for joining us. And tell us, what are you going to be talking about today?
So I'm primarily going to be talking about robot-assisted vasectomy reversal. And first of all, it's great to see you, and I'm thrilled that you guys are doing the Drive for Men's Health. I think this is an outstanding initiative. Are you still getting me there?
Oh yeah, of course. You look great.
Okay. So it's a really wonderful thing that I think you guys have put together, and it's an honor to be involved in it. So thank you for having me. But I primarily wanted to chat about the robot-assisted vasectomy reversal, which I've been very fortunate to get to perform out of my home hospital here. So I'm in Austin, Texas, and I had the opportunity to spend some time with Dr. Pericotto in Florida and see his technique, and and have been really enjoying adding that as a part of my practice. So I'm a reproductive urologist and did a microsurgical fellowship. So I was really trained in using the operative microscope to perform vasectomy reversals. So there's about 500,000 guys in the United States that have a vasectomy reversal done every year. And out of those guys, about 6% of them will change their mind sometime in their lifetime for different circumstances and decide that they want to have more children in the future. So the primary option those guys typically consider is a vasectomy reversal. So when you think 6%, it sounds like a small percentage. When we're talking about that magnitude of number of people in the United States, that's actually about 30,000 men. So it's a lot of guys. So we really advance in our techniques on vasectomy reversals to increase our outcomes and improve our success rate significantly early in the 1970s when the operative microscope was added to use magnification to help us see these tiny little tubes that we're putting back together to get a guy's fertility back to where it was before his vasectomy and allow those couples to have children again. And really amazingly, since the early 1970s, there have been little tweaks here and there. There have been little things as far as instrumentation that we've done, maybe some advances in the optics a bit, but there's been no major overhaul of that system to really try to advance the technology at helping us improve these men's fertility or helping the surgeons do it in a way that might be more appealing to that surgeon. So even though I was formally trained from a microsurgical standpoint, I've really embraced the robotic technique that I learned from Dr. Pericottle, and I've been thrilled with it. And honestly, it's my method of choice now. So I'm sure there's been a fair amount of discussion about robotic surgery, but again, the basics of it is rather than the surgeon being standing right there above the patient, the surgeon is in a console in the corner of the operating room that basically looks like a big video game machine that we put our head into, and we have a monitor that's feeding us 3D high-definition images that are real-time images that are obtained from a magnifying camera above the patient's body. And then we use these little joysticks to drive microsurgical instruments. So there's a lot of nice things that we think are advantageous for this technique over the old microscopic one. So, you know, no surgeon likes to think that he has a tremor, but when we're talking about really microsurgical surgery, we probably all have a little bit of a tremor. It's debatable on each surgeon whether that's affecting their surgical outcomes, but the robot has zero tremor, so it takes that out of the equation completely. So there is an improved stability with this modality. Quite frankly, from a surgeon ergonomic standpoint, it's an awful lot more comfortable to be sitting in an ergonomic console doing robotic microsurgery than it is being hunched over a microscope and being in that position for so long. And so really it's a lot more comfortable, which means that if your surgeon is doing multiple cases in a day, it's a lot less fatiguing for them to get through their surgeries during that day. And I've certainly found that to be the case for myself. There's another aspect called scalability of motion. This means that if I move my finger that much, I can set it so the robotic instrument only moves a fourth of that much. So that's a really nice aspect when we're talking about microsurgery, when we're talking about very fine, meticulous movements that can make or break the operation. The camera gives you beautiful 3D high-definition visualization. Operative microscopes are very good at magnifying. They give great images, but I'll tell you, I certainly feel like I can see better with an operative microscope than when I do with an operative microscope with the robot. It's just a really pretty picture. It's 3D high definition. It gives the surgeon more autonomy and it gives you more control. And quite frankly, we all like to have as much control of our operation as we can. So you can.
So tell our audience, like when you're doing it microsurgically, is it just you, or do you usually need an assistant? And is that different from the robot?
Yeah, it is. And so when you're doing it microsurgically, it's you standing on one side of a microscope. The patient is below the microscope, and across from you on the other side of the patient, you have a surgical tech or a doctor in training or what have you that's going to be assisting you. The issue with that is you may not always get the same assistant. And once you've trained them up, they're usually pretty proficient at helping with microsurgery, but the fact is now I'm relying on somebody else, someone else's technical capabilities in their hands to help me with my operation. And most of us like to be in complete charge of our operation, and every move we make, we want it to be perfectly the way we want it. And so that is a little more challenging when you've got an assistant that has to do it exactly how you would want them to do it. And some are better than others, quite frankly, and it takes some training to get them where you want them. The robot is always going to do exactly what you tell it to, and so you really get control of all aspects of the operation, and you need very minimal from an assistant to help you get through that surgery, because when I'm sitting at that console, I have the capability of manipulating 3 surgical instruments and the camera simultaneously. I can do everything I want to do as far as moving my camera, showing me the angles I want to see, moving 3 different instruments. So that means I really don't rely on anybody that has to help me or know how I want to do it. I'm able to do it exactly how I want to. So really we have a big de-emphasis on a specialty trained, skilled technician or assistant that you really want at a high level to help you so you get good outcomes on this surgery. From a technical standpoint, the other really nice thing about it, just from the surgeon's perspective, is that when you're in a microscope and you're looking through that, sometimes you're in a difficult surgery and you have to step back for a second and take a break, catch your breath, and go back in there when it's a technically demanding part. When you do that with a microscope, it takes very little motion for your entire field to change and move and not look exactly the way it did where you set it. With the robot, you can back out, take your breath, come right back in, and absolutely nothing has changed or moved. It's really nice and stable. And what we're seeing, Dr. Pericato has already published articles on this, and I'm seeing in my experience as I'm keeping track of this, is that the more robotic surgery we do, the faster we get at it. He showed his robotic times were faster than his microsurgicals, and mine are getting there as my volume goes up. So there's an awful lot of nice potential advantages of the robotic technique for this specific operation. So, you know, as we keep advancing, surgery is always going to be an evolution. You look at where we were and where we are. You know, it was not that long ago before we even had operative microscopes to use, and that was a really great step in a good direction. But as we evolve, as our technology evolves, we get better technology that helps us become better surgeons. I think the robot, it's a beautiful application, and really I think ultimately we're going to see more surgeons getting very good at doing these type of robotic surgeries, and I think it's a service to our patients ultimately.
I agree with you. I mean, we utilize robot for a lot of procedures. Actually, utilize robot for majority of the procedures you utilize it for. And we definitely know the advantages of it. I mean, there's also cons with the robot. There's a cost issue that comes with the robot. But you know, I think in certain cases, the cost issue is definitely outweighed by the benefit it may provide the patient. Now, obviously, it's and our thing is it's a discussion you have to have with your patient. I mean, you know, we've never said the outcomes are better. They may be. We just don't have enough data on it yet. But overall, from a procedure standpoint, we feel it does enhance our skill set. Wouldn't you agree, Dr. Cavuzzi?
I absolutely agree, and I would say the same thing. I have a very frank discussion with my patients, and I offer both options. And I do microsurgical ones still, but I certainly like doing the robotic ones better, to be honest. And the more and more I've done them, I'll be honest with you, I feel more comfortable doing them robotically than I do microsurgically now, where I was formerly trained microsurgically to do these. So that's how nice that robotic device is, I think. There is a cost consideration, but I'll tell you, with negotiation with hospitals, my microsurgical fee versus my robotic one, there's only about a $300 difference. So, you know, yes, that is a difference, but it's pretty feasible for most people that are willing to go through. And when it's adding those types of advantages, a lot of people will think that's worthwhile. That being said, I certainly agree we don't have the data or the evidence that it's a better operation yet. The outcomes are very similar. The incision is the same. The recovery is the same. But what I'll tell you is from the surgeon's perspective, I think there are a lot of nice advantages. And quite frankly, if I'm having surgery, I would prefer my surgeon to do it the way that they like to do it. That's personally my take.
Now, Cavuzzi, thank you so much for the talk on the use of the robot, a very evolving technology, and its use in cases for infertility. I have a very practice. Can you tell us about that? It's a family-run practice, and it's a very unique situation. I think this is what's going to happen to healthcare. What the system you're in, I think it's going to be consolidated care where people go to one place to get multiple levels of care. So do you mind taking a second and telling us about that?
Absolutely, I would love to. So I'm very fortunate in the practice that I'm in. As far as the setup, I couldn't ask for it to be any better for my personal practice and what I'm able to provide for my patients. I'm in Austin, Texas, and my group is Austin Fertility and Reproductive Medicine. And we're really fortunate because I get to practice not only with partners I like, but partners that are family. And so my father and my brother are both reproductive endocrinology and fertility specialists. So they're specialists on the female infertility side. And we have a very unique scenario where we have both sides covered under one roof in one center, where we really provide couples care, looking at both sides of the couple to try to optimize them to give them the best odds of pregnancy. Whether that's a couple that's come in after vasectomy and they want to look at options like vasectomy reversal versus sperm retrieval IVF, or just the 1 out of 7 couples in the United States that's struggling achieving a pregnancy. When we break down those statistics, what we see is out of that 1 in 7 couples, 20% of the time there's male factor involvement that's solely responsible for that couple's decreased fertility. An additional 30 to 40% of the time there's male factor plus female factor. So what that means is 50 to 60% of the time that a couple is struggling to conceive, there's male factor involvement. So where we used to just kind of ignore the guys and only pay attention to the women, well, now we know we're important too, for better or worse, right? But the good news is we've learned an awful lot on both sides, and it's given us a great advantage to take care of couples together. And I hope that's a trend that we go in nationally, is rather than just focusing in one place on the man and one place on the woman, that we're doing a better job coming together, which a number of centers have, to try to optimize couples care and give that couple the best chance of going home with their baby. Oh, I may have lost sound there. I can't hear you. Can you hear me still?
Hey, Dr. Booth,
Okay.
thank you so much for letting us know about your practice, but more importantly, letting us know about the procedures you do and the technology that you use. You're welcome to be on, but we're going to be shifting things now to Dr. Richard Lee. Dr. Richard, how are you, man?
Hi, how are you?
Good. Dr. Richard Lee is assistant professor of urology at Cornell up in New York City. And Dr. Lee, are you going to be coming to see us tomorrow when we arrive in New York?
Going to try to. You guys are coming bright and early, right?
Yeah, we are. We're running about a little behind, so we may be there maybe a half an hour late. But we are going to try our best to stay on time. Now, Dr. Lee is going to continue a conversation we were having earlier today, and that's lower urinary tract symptoms. We learned a lot about BPH, enlarged prostate, the medical aspect, the surgical aspect, but Dr. Lee is going to spend some time talking about metabolic syndrome and LUTS, and is there a connection between the two? So Dr. Lee, would love to hear from you now. Thank you so much for joining us today.
Terrific. I appreciate the opportunity to speak. Now, I've got a number of slides. I'm just trying to figure out how to load them onto...
Yes, so if you press the green button on the left, it'll go to screen share, and you can share your screen in several different ways.
Perfect. Okay, so maybe I'm going to start here.
Yeah.
Let's see. Okay, so we're going to... Can you guys see that?
Yeah, we can see it perfectly. Thank you so much.
Okay, so I'm going to very briefly chat about the metabolic syndrome and whether or not there may be a potential correlation with lower urinary tract symptoms. It sounds like you guys heard a little bit about big prostates and how that can affect a man's ability to urinate. I'm going to talk about sort of what I think is an exciting new topic in my area, basically the concept of whether external factors other than just a big prostate or an overactive bladder may lead someone to have a lot of urinary symptoms. So I'm going to start off with basically a map of the U.S. from 1985, and this is data from the U.S. Census Bureau. And what the Census Bureau did in 1985 was survey the country and ask how many patients are overweight, and they defined this as a BMI of greater than or equal to 30, or at least 30 pounds overweight for a person who's 5'4". And what you can see, and hopefully you can see my arrow moving around a little bit. There are a couple areas of the country with no data, but you can see, there are a few areas such as California, the Southeast, a little bit of the Midwest, where you have anywhere from 10 to 14% of the population that is considered obese. Now, fast forward to 2008, which is probably the most recent year that we have data, and you can see that the map has changed significantly. In fact, what you see here is a whole number of new categories. Number one, we see data for the entire country finally, but we see, in fact, states where over 30% of the people are considered overweight or obese, and the states where there is only a minor degree of obesity have increased, and this is sort of a concerning trend that I think we all as physicians have seen over time. Now, what does obesity mean? I mean, as a growing epidemic, we know that in 2006 alone, over 72 million Americans were considered obese, compared with only 23% in 1994. In fact, today the average American is 23 pounds overweight. That's a cumulative 4.6 billion extra pounds that all of us are carrying as we walk around. And this is translated into greater expenditures in healthcare. In fact, it's estimated that about $150 billion in 2008 were due to complications or due to treatment for obesity. In fact, this comprised about 9% of all medical spending in that year. And in fact, to drive the lesson home, an obese patient has about $4,900 in medical bills per year, compared with $3,400 for a healthy patient who's a counterpart. Now, how does this have to do with lower urinary tract symptoms? And so we're going to sort of shift into a couple of the studies that I just want to point out. This is Charlie Parsons in San Diego, and he drew on data from the Baltimore Longitudinal Aging Study, and he asked the question: do metabolic factors associate with changes in prostate size? So we've always traditionally learned that prostates tend to get larger as men get older, but perhaps that growth can be influenced by other factors. And in this cross-sectional study, he looked at the association between BMI, symptoms, and prostate size. And in fact, as you can see from the data here on the right, increasing prostate volume was associated with an increase in BMI, an increase in fasting glucose level, and an increase in diabetes prevalence. This is a study from the NHANES 3 iteration, where over 2,300 men were surveyed in a cross-sectional analysis. And what the authors sought to do in this study was to, let me see if I can make this a little bit larger for you, was to look at the relationship between lower urinary tract symptoms, getting up in the middle of the night, having a sensation of incomplete emptying, a weak stream, hesitancy, and associating that with various elements of the metabolic syndrome. And I've attempted to highlight sort of the relevant areas on the table here. So elevated blood pressure or hypertension, metabolic syndrome definition, glycosylated hemoglobin, which we use as a marker for diabetes, and HDL levels were all in fact associated with an increase in lower urinary tract symptoms in men. This is a table from the Boston Area Community Health Survey. We call this the BOX study, where over 1,900 men were surveyed in a cross-sectional analysis. And the prevalence of the metabolic syndrome, which you can see on the y-axis here, was correlated with the AUA symptom index. Now, the AUA symptom index, as many of you know, is a quantitative marker that we use to assess how symptomatic patients are in terms of their lower urinary tract symptoms. And in fact, as you can see, that the prevalence of a higher AUA symptom index seemed to be directly correlated with an increase in the metabolic syndrome. Now, what does this mean? So we've got a number of cross-sectional studies that suggest a linkage between lower urinary tract symptoms and the metabolic syndrome. This has implications, we think, for different ways to treat LUTs. So instead of just, for instance, giving medical therapy or offering surgery to patients to treat an enlarged prostate or an overactive bladder, can you in fact treat that same symptom complex now by really addressing people's glycemic control, people's high blood pressures, people's lipid levels? And what are the implications for how we're going to see and treat LUTs in a society where obesity is increasingly seen in patients, even all the way down to children? This is a schematic that talks about how different factors may interplay in terms of how lower urinary tract symptoms evolve in the metabolic syndrome. So obesity, dyslipidemia, increased age, changes in blood pressure, changes in physical activity, changes in the nervous system may all lead to growth of the prostate and dysregulation in terms of how the bladder is working. So I hope that was a very brief but cogent primer in terms of how we think one of the newer areas in my field is evolving. And I'd be happy to take any questions or
well, that is great. I mean, this is something that we definitely, it gives a more broad, you know, discussion, because, you know, we've just been talking about specific organ, but what you've enlightened us with is you got to think about the whole body. You know, where do you think this obesity epidemic is going here in America?
Well, I think, you know, at least the traditional science have suggested that it's just continuing to increase. You know, it's a worrisome trend that we see not only in adults but in children, and it's got a ton of implications, I think, for not only, you know, cardiac disease, but also how, you know, we in the different specialties, where, as you mentioned, we're all pretty siloed in an environment where, you know, patients go to subspecialists with specific problems. I think there's things like this, I think, talk to much more of a collaborative or intergroup effort. You know, I have the great fortune to work in the men's health center here at Cornell, and so, you know, my office sits right next to an endocrinologist's office. It sits right next to a cardiologist's office. It sits next to an internist. So, you know, being able to really provide multi-modality care, I think in this instance really serves to help the patient.
I mean that's great. I mean, I think that's where healthcare is going. You know, multi-specialty centers. There was a New York Times article recently about these centers that are opening up. But Dr. Lee, thank you so much for taking time out of your busy schedule to be with us and starting a conversation with men about men's health. We're actually here in Santee, and we're going to start driving up to Lumberton now, in Lumberton, North Carolina. So, Dr. Lee, hope you continue to follow us on our website, driveformenshealth.com. And thank you so much, and I really want to see you there tomorrow morning when we arrive in New York City. Thank you for taking the time.
Looking forward to it. Safe trip, guys.
See you. Thank you, buddy. Thank you. All right, guys. So I'm just waiting for Sijo here. We're kind of we kind of shared some space here. Where is everybody, dude? Huh? See me. That's Armand. We're not talking about it right now. We're live.
So I got Each of you, one cheesecake and one pecan pie.
Oh my God.